Good afternoon, everyone. We have a fantastic webinar for you today entitled Health Disparities in PAD, What to Know as an Anticoagulation Provider. Our presenter today is Dr. Foluso Fakorede, and our moderator is Dr. Surabhi Palkimas. Next slide. All right, so to introduce our presenters today, Dr. Foluso Fakorede is a physician, entrepreneur, and advocate for healthcare injustice. He spent his formative years in Nigeria and immigrated to America as a young teenager. He was a standout student. He obtained a Bachelor of Arts in Biology and a minor in economics from Rutgers University, and he received his medical degree from UMDNJ Robert Wood Johnson Medical School in Camden, New Jersey. He completed his internship and residency in internal medicine at New York Presbyterian while Cornell Hospital. He returned to New Jersey to complete a fellowship in cardiology, interventional cardiology, and endovascular intervention at Cooper University Hospital in Camden, New Jersey. And during his fellowship, he was honored with the distinction of Chief Cardiology Fellow. Dr. Fakorede specializes in preventive cardiovascular management, women's heart health, and catheter-based procedural focus in coronary atherosclerotic disease and peripheral atherosclerotic disease. He currently serves on the Society of Cardiac Angiography and Intervention, Vascular Disease Committee, and is part of the American Heart Association Patient Advocacy Group. In 2015, Dr. Fakorede started Cardiovascular Solutions of Central Mississippi with a mission to educate and provide access to quality healthcare for all. He's become a national voice in the fight against the impact of health disparity in underserved communities. As the co-chair of the Association of Black Cardiologists PAD initiative, Dr. Fakorede has been at the helm of working with congressional lawmakers to establish the first ever bipartisan PAD caucus, whose mission is to support legislative bills to stop the virulent practices of preventable amputations and to educate communities about legislative activities aimed to improve PAD research, education, and treatment. Dr. Surabhi Palkimas is a member of the AC Forum Inclusion, Diversity, Equity, and Allyship IDEA initiative and has more than 15 years of pharmacy experience in various clinical and leadership roles. She received her BS in biochemical pharmacology from the State University of New York, Buffalo, and her PharmD from Massachusetts College of Pharmacy and Health Sciences. She completed her PGY1 pharmacy residency at the Hospital of St. Raphael in New Haven, Connecticut, and is in the process of acquiring an executive MBA from the University of Denver. She recently took a leadership role in 340B contract pharmacy at the University of Colorado Hospital. Previously to that, she was practicing at the UCH Benign Hematology Clinic, where she worked under a collaborative practice agreement to provide comprehensive anticoagulation and formulary management, as well as support the care team with transitions of care for benign hematology patients. Next slide. And so neither of our presenters today have any disclosures or acknowledgements of financial commercial support. And this webinar is accredited for CME, specifically ethics CME, if you need that. We will put the link here in the chat, and the instructions are here on the screen. And with that, I will turn it over to Dr. Fakorede.
Good afternoon from Mississippi, Sarah. Thank you for that wonderful introduction. And just wanted to acknowledge your teammates and our co-moderator for all the work and efforts that has led to this wonderful webinar being placed together today. I have a lot to say, but I'll keep it brief because one of the major questions I get is why PAD and why the Mississippi Delta? And I hope to convey that to the audience over the next couple of minutes. Peripheral Arterial Disease Awareness Month is September. I start off by reminding folks that PAD is the most chronic, prevalent, deadly, costly, and least known of all cardiovascular diseases to date. It's sad. It's one of those diseases that is similar to cancer in terms of how slow, how progressive, how deadly it is. But 1 in 4 Americans have never heard of peripheral arterial disease. And so we acknowledge the month in terms of trying to raise awareness on this topic, but also we will try and get to why a kid from Nigeria ended up in New Jersey and ended up in the Mississippi Delta. But you have to understand my side of service first. So why Mississippi? Well, Mississippi has had probably the highest percentages of African Americans out of all other states due to its sobering history and a sad history of slavery. Cotton was king here in the Delta once in the past. Mississippi was actually the third wealthiest region in the area. But over the past couple of decades, as people have heard, it's now the poorest state. But an enduring legacy of that is that majority of my patients are African American, over 80%. And there is also the social determinants that comes with that history in terms of enduring poverty. 7 out of 10 residents here have problems in paying their medical bills. The average Mississippian spends an exorbitant amount in terms of the cost to see a specialist or their primary care or gatekeepers relative to the total income of someone who resides in Massachusetts. It has the lowest number of physicians per capita. It is a vascular specialist desert, as well as other specialist deserts. A lot of folks are either underinsured, but 65% of the uninsured population look like me, they're African American. It's one of the states that did not accept the Affordable Care Act. And that has led to a lot of issues in terms of access to quality care. We only have 16 podiatrists in this state. I am the only cardiovascular specialist in this county. My catchment area is about a 2.5-hour radius. And it is one of the highest regions in terms of highest vulnerable hospitals. There are 7 counties in this state without hospitals, believe it or not. And it is the only state in the diabetes belt of America, 644 counties, where every single county is represented and has the highest complication rate that you can think of when it comes to blindness, amputation rates, heart attacks, strokes, and hypertension. And unfortunately, we saw that with COVID. It had the worst COVID-19 death rates in the country. Next slide, please. And so when it comes to peripheral arterial disease, one of the complications of peripheral arterial disease, if it's not caught early, is critical limb ischemia, non-healing wounds, and then an amputation. Unfortunately, an amputation first strategy is offered to a lot of patients, predominantly those who live in regions like the Mississippi Delta, especially to patients who are minorities, especially patients who do not have the knowledge to understand what the steps should be to save and preserve your limbs. And so we wrote about this in the Black American Amputation Epidemic. I recommend everyone read it. It talks about the systemic policies, the academic or medical practices, and institutional policies also that are in place that work in a fragmented form and exacerbate health disparities and has led to groups being afforded an amputation first strategy versus their counterparts. And so I definitely recommend the audience to take a look at that. And it explains basically the foundation as to their stories from the perspective of these patients. Next slide, please. So as we're all sitting here, we've spent over 10,000 hours or for some over 26,000 hours studying, pharmacotherapies or going through medical school or going through, our, advanced programs in terms of allied training. But one thing that we all share in common is that we do a very poor job at preventative care. Especially when it comes to this prevalent disease. Peripheral arterial disease patients have a significant mortality and morbidity outcome when it comes to their lack of recognition, lack of screening, the fact that they don't have access to quality specialists, as I mentioned earlier, but access to medical therapies. The therapy is being initiated upstream so that we can prevent that, right? Prevention is better than cure. So what's happening to these patients? Well, when you look at the recommended, the guidelines for treating and preventing PAD, what are the strategies to prevent? It's lifestyle modification. It's making sure that your risk factors are controlled. And these risk factors are only getting worse as a population, as we're seeing with diabetes and obesity, as I call it, the diabetes epidemic in America. And also you're seeing that institution of preventive strategies like antiplatelet therapy, anticoagulation therapies, the cholesterol lowering medications, your statins, your ACE and your ARBs, your supervised exercise testing, all these are underprescribed and are not utilized. And then the cessation counseling is also underutilized. And so we can do better as a medical community when it comes to prevention, especially in our curriculums. I think we have to change that mindset. And that's something that I always try and highlight when I speak to my colleagues, especially those that constitute the multidisciplinary team, such as everyone who's watching this forum today. Next slide, please. So what does an amputation epidemic look like? Well, it looks like this. I know it's lunchtime and I know people are either eating or have, but this is what I see or what I saw on first presentation in patients who walked either into my office or I walked into their hospital rooms for the first time. I took these pictures on first initial visit. So the fact that people do not even take off their socks or are not told to take off their socks, who are at risk for this costly and deadly condition, unfortunately, at the end spectrum of this is gangrenous foot. Their foot looks gangrene or non-healing wound that doesn't heal. And these people have suffered in silence due to this violent practice of a preventable condition where 90% of the condition is preventable if caught and treated in a timely fashion. But there's this blindness that occurs in medicine where we have dehumanized it and we look at it in the lens of it's just a limb, it's just a toe, it's just a leg. No, these are lives and livelihoods. These are brothers, sisters, uncles, aunts, fathers, mothers, brothers, sisters. These are our parents. Both my parents are diabetics. This could be any one of them because diabetes being known the #1 risk factors for critical limb ischemia and for those patients who are more likely to get an amputation. Simple fact, out of the 200,000 amputations that occur every year, 130,000 are on diabetics. And 80% of these patients were diabetics. And a sad fact and a sad statistic is that 80% of all amputees, major amputees who are diabetics will be dead within 5 years. 80% of all these patients are unfortunately dead. Next slide. And so in coming to the Mississippi Delta, one thing we did, and excuse the headline should be, the Mississippi Delta Miracle, which is basically coming in. When I came to the Delta in the 2015, I was in a hospital setting where there wasn't a vascular specialist. As I mentioned, I'm the first cardiovascular specialist in this county. And so what I did was I engaged not only the community, but educational opportunities for my colleagues and the doctors, physicians, the advanced practitioners, and providers, the pharmacists, the physical therapists, educating them as to what we can do, offering these patients a limb preserving strategy, and basically being antithetical to what the previous practice was. As you can see on the left, there were 56 amputations being performed in 2014. And so what we tried to do is to offer them limb preserving, not only medical therapies, but procedures. If you can successfully go and open up a blocked artery and you have either the minimally invasive skill set or a surgical route, that is shown to decrease the chances of an amputation by 90%. And in doing so, we decreased early amputations from 56 all the way down to 7. But we also saw that we had a rise in limb preserving procedures because we started seeing more patients from catchment areas coming in for these procedures. So that was an 88% reduction in amputation rates. And why is that important? Most of these patients will die from a major adverse cardiovascular event or will suffer a major adverse limb event. So what are the major adverse cardiovascular events? It's stroke, heart attack, or death. And what are the major adverse limb events? Is an amputation or a repeat intervention. What is the economic benefit of this? Is that an amputation costs the patient about $150,000 a year. And the median income of someone in Mississippi is $38,000, $39,000 a year. So you're saving dollars not only to the patients, their families, but to the community, and more importantly, to everyone here who pays taxes, because 75% of that bill is funded by our taxpaying dollars. So that was the benefit of showing the clinical, economical, and human impact of this. Next slide, please. Community engagement and educational awareness, very important in terms of trying to meet people where they are. You know, everyone hears that. It's not easy. We're not taught that. People are comfortable in large forums and small forums. Some people are comfortable in engaging their communities. And especially if there's a concordance between a physician such as myself and the community, this was easy. It was an easy ask. And I believe in the direct-to-consumer approach. Direct-to-consumer approach. Go straight to the source. So it's either interacting with that patient, interacting with that community, addressing who you are, services you provide, showing how you are both interpersonally competent and technically competent, and making sure that you understand the strengths of the community and the weaknesses, and being an advocate on their behalf, teaching them and educating them and informing them on the things that they need to know, and therefore transforming their lives and their livelihoods. And that's the importance of community engagement and educational awareness campaigns that we do here so often. Next slide, please. I think this is the last slide. You know what you love, you know what you're passionate about, you know your mission, you know what you're great at, and you know what the world needs. I saw the need here in Mississippi. I knew that I was great in not only being a limb preserving endovascular specialist, but also my mission and my passion was to help those who, you know, were who lacked the megaphone, those who lived a life that most people had dehumanized, making the invisible visible, and putting that with my technical competence and building a compassionate team around that. So that's basically my message for anyone who's watching this today, is to basically combine that interpersonal competence and technical competence. And that usually engenders care-seeking behavior by a community, one that has had a long-standing mistrust with the healthcare system, or one that just thinks that, hey, listen, you know what, I don't like to see doctors. But if they can trust you and they know that you care about them and you treat them with compassion, then you know, you're trying to maintain and, you know, attain a just and fair health outcome for them, which is what equity is. So my job is to bridge the gap in health inequities in care and to continue to address this epidemic of amputations. And I think that's the last slide. Thank you for your time.
So thank you very much, Dr. Fakorede, for sharing your experience with us, sharing the history of Mississippi Delta, having these difficult conversations that we don't get to have daily in our practice. I applaud you for all the work you've done. Thank you for sharing your mission and igniting that light within us to be doing the same. I don't think we're doing justice to what the work you do. So I wanted to share a case study and walk through some of the examples through this case study to help you share more of your experiences with us.
Sure.
So we have a patient named Sadie. She's 65-year-old Black female who's African-American. She's from a rural Jasper area, Arkansas. She had a stroke about 3 years ago. She also has history of hypertension and has dipped tobacco since the age of 8. She is, her education level is about 4th to 5th grade level. She lives alone. She's currently only taking aspirin 81 daily. Sadie has pain in her legs when she walks, has trouble with transportation, The nearest clinic is 14 miles and she does not have a car. Due to the pain in her leg, she has not visited her PCP in over 6 months. She does not have any health insurance either. Sadie relies on her local pharmacist, Kevin, for health-related concerns. During an encounter, Kevin notices a non-healing wound on Sadie's right pinky toe. Sadie says that it has been there for a while. Kevin is also a member of Sadie's church and they both have a very strong relationship. Kevin is happy to educate Sadie on her health conditions and risk factors, and he stresses the importance of adhering to her medications, seeking medical attention whenever she has symptoms like those experienced before with her stroke. Kevin also stresses the importance of taking her medication and notifying a physician when she experiences any of those symptoms. So breaking this case down a little bit further, I have a few questions for you, Dr. Fakorede. The first one being, should Kevin provide this level of care to Sadie as a pharmacist, especially given her comorbidities?
That's a great question, Dr. Palkimas. This is a typical Mississippi Delta / Fakorede patient, and it was well put together by yourself and your teammates because it highlights a couple of things. One, it shows Sadie who, number one, is someone who has a lot of cardiovascular risk factors. Her age, she's over age of 50. She is nicotine use. So, we're taught that we're just asked to use smoke in all our studies and research studies, but she dips tobacco, which is actually more common in my patient population. Predominantly African-American elderly females actually more dip or chew than smoke. And people are probably wondering, 8 years old? Well, yes, a lot of their grannies took care of them. And what's common is that when a grandparent is dipping or chewing nicotine, they actually give it to the kid, like, hey, listen, just hush up. So you do see it. I didn't know this till I moved down here. And culturally, that's understanding your patient population, not presuming that what happens in Upper East Side of New York or in Bergen County, New Jersey, or anywhere in Jackson, Tennessee is the same thing that happens here. There are regional variations, but also there are social determinants that play a role. She's uninsured, lack of transportation, very common here. But she has someone that she trusts in the system who happens to be a pharmacist. And Kevin's role is to understand his scope of practice. He's the first point of contact, medical contact in this woman's life. He will determine if she lives or if she dies. What do I mean by that? The next recommendation he makes is very important. And so his job is not to play vascular specialist. His job is to say, hey, listen, I recognize that there's a problem and I recognize who I can send you to or group of specialists I can send you to address those problems. I also recognize there are challenges in getting to those people and how can we figure out what the solutions are. So in terms of what level of care, it should be in the confines of what he is trained to do and what he is as a human being, but not to exceed it to him acting as a vascular specialist.
That's beautifully stated. And I think one of the things that I learned from you, and I want to share with everybody, is that, really the importance of studying the population where you're practicing. So if you were to be practicing in different states and you just recently moved to that state, yeah, we take the law exam just to get proficient and get our license up to date. But do we really spend the time to learn our population, learn our patients that we care for outside of what we see in clinic? So before we form bias or any sort of understanding of those patient population, I think it's good to ask the questions such as, do you smoke? It may not be the right question in Mississippi Delta. We need to ask other things such as, are you dipping? And also to understand what our patients are going through in the community outside of our medical practice. So thank you so much for that. Absolutely. So my next question for you is, can you share how your approach of meeting people where they are, namely through churches, faith-based institution, has helped you and your team educate, build trust, provide people with resources typically unavailable in under-resourced communities?
Yeah, absolutely. It's been the core foundation in building what I call community navigators. So when there's just one of you and there is a lot of patients, unfortunately, who are sick, and we know where this trajectory is going as care providers. We know what the numbers are doing in terms of risk factors in this country. We know that the number of physicians are not going to be able to meet actually the population that we're going to see in terms of their cardiovascular risk or ischemic heart disease or vascular disease in the future. So we need to form allies, collaborators. Allyship and collaboration is important. It's not only with the pharmacists, but also I believe that we have to go and see how we can meet these people at either their homes or where they're comfortable. And so, yeah, most of us, we're not going to start knocking on people's doors. But where you find a lot of people here in the Delta, which is a predominantly African-American population, are in the faith-based community, churches. And it's either churches or it's, in civic organizations, fraternities, sororities. And what you find, the commonality is every single major player that you can think of, from a healthcare administrator to a politician to a CEO of a hospital to the providers in the community to the nurses in the community to the pharmacists and the physical therapists, nutritionists, all mainly attend the same circle of churches. And so in going to those churches, you save yourself a lot of visits. I don't need to spread out and go to a lot of places. I need to face an audience, tell them who I am, and explain why I'm there. I'd never introduced myself as a vascular specialist. I always introduced myself as a cardiologist. Why? Because sometimes it's just too much to break down. Remember, we've gone through years of training. I started out with that. The way we speak and the way we interact with regular folks, we need to keep it simple. They always say use the KISS method. So who am I? I'm a cardiologist. I happen to, treat a lot of patients with high blood pressure, high cholesterol. I happen to treat a lot of patients who come into my office who might suspect they have gout, or as we say down here, the gouch. People who might have arthritis, which might be, my 80-year-old grandmother who's had diabetes and that neuropathy for a long time and just attributes her symptoms to back pain and neuropathy and arthritis. There are people who've had diabetes for a long time and, keep on eating the wrong things. And that could lead to a lot of problems like, problems with your vision, problems with your kidneys, problems with your heart, problems with your circulation, problems with, basically your mental health. And some of these things can be prevented. And so in speaking to them in a large audience and tell them what are their options. So what are their array of options? Well, not everything is medicines. Lifestyle and dietary modification is the number one preventable cause of death worldwide, to be honest, right? Before we start throwing medicines. And then we say, well, then we can go into medical therapy. And then guess what? If you have this non-healing wound and ulcer and they tell you you need to have your toe chopped off or your leg chopped off, guess what? That is not the first line therapy. There are other things that can be done. There are people who are specialized to treat that. And then a light bulb goes off and you ask them, who has been offered an amputation or who knows a family member who's been amputated? Everyone at church raises their hand and they tell you they know people. And so it's having that discussion and making yourself approachable and then being friends with the nurses who serve those churches or their doctors who serve as community navigators with those churches and the community and saying, hey, listen, can we have an event at your church or your faith-based organization or your mosque? It could be any form. Don't forget, Native Americans do matter too. That is a faith-based community. The Latinx community too. They do have a faith-based community. So this is not just the Black population I'm referring to. This is across the board. And what has helped us is building that collaborative spirit where we can engage with those navigators and then providing whatever resources that we can bring to them and whatever resources within the church that they can bring out as well and combining those to take care of those patients. and referring them back to their primary care providers or referring them to other services within the community to get their problems addressed.
Yeah, that's beautifully stated. I think we, again, speaking for myself as a pharmacist, in pharmacy school, had to do a lot of community engagement and doing public service, classes and courses like that. But really, I don't know if I've spent that much time really serving my community outside of my work. So I think this is a great example of how we can simply do that and maybe carve out a little bit of time to meeting people truly where they are. So moving on with the case, Kevin recognizes Sadie's risk factors for recurring stroke. So he's always looking for opportunities to speak with her about dangers of dipping, a habit Sadie has had before her stroke. Kevin suspects Sadie may have PAD based on how she described her pain in her legs when she walks. Sadie also has a non-healing wound that Kevin is worried about. So Kevin is also concerned along the lines about Sadie's diet, as she has trouble affording and finding healthy foods. The grocery store is 7 miles from her home, and she instead relies on local dollar store or quick fast food. Just taking that information for a little bit, I have another question for you, Dr. Fakorede. Does lack of access to healthy food options qualify as a social determinant to health? If so, what are the healthcare outcomes associated with this?
Yeah, so 1 in 10 Mississippians, I think I'm getting this right, are food insecure. And that translates to, 5 in 10 Mississippians are either pre-diabetic or diabetic. When people talk about health disparities or disparities in care, this table that is listed, that is highlighted in front of us right now, is listing everything from social to economic to educational and neighborhood environmental factors that determine one's health. And we always say health is wealth, and there's a reason, because we in the medical field focus on that last part, that last column. And that's what we're taught in schools. It's like, hey, listen, just focus on being linguistically appropriate and making sure your patients have access to insurance and making sure that, they have the right medications or therapies. But one thing that we need to define and we have to understand is that there are people who are economically, just economically unstable. There are people who've had economic instability for decades. So that also affects where they live. That affects what schools their kids go to. That affects the ability to afford healthy meals, because their Whole Foods might not decide to come and place a Whole Foods, department here in the heart of the Mississippi Delta, where the average income is less than $40,000 a year. So, there are things that factor in. And so people say, well, what about your Walmart or your Kroger's grocery store, which are the only 2 grocery stores around? If the time it takes for Sadie to get to to either one of those 2 stores, due to her lack of transportation, not only the time but the cost, she has to pay a family member to drive her to that store. So that's $20 she has to go find. An uninsured lady has to find every single time she needs to go shop. And when she gets to the store, do you think she's going to be looking at all the, hey, what are my options here? Can Sadie read a food label with her 4th grade level? Does she understand what calorie counts are? There are a lot of things we take for granted. Not everywhere has equal access, right? To those kind of things. And so, yes, it does play a role. Social determinant is the #1 cause of health disparities in America. It's not a genetic construct. It's a human construct created by men and women. This is something that has existed for decades. When people talk about health equity versus equality, there have been disparities in all of these segments of care, all of these segments of housing, all of these segments of economics, all of these segments of physical environments, all of these segments of access to quality food and healthy options for decades. Not to mention, let's top that up with discriminatory practices and lack of community engagement and support systems and the educational aspect. So what does that build? That builds a community that has not had, the circumstances or the resources that were exacted for them to reach an equal outcome versus the rest of their counterparts. That is the inequities that we're talking about. Versus equality, which is just saying, hey, let's give everyone the same thing. Like that's not the answer. Let's just give all of you a Whole Foods. You can put a Whole Foods in every single county in this country. You will still not address 80% of that problem, which is the economic inequities and everything that I've mentioned, which is all the first 5 columns before the health column. And that is something that we have to address with colleagues. We cannot solve that with our medical hats. We have to talk about policies that need to, and that's where advocacy comes to play. We have to talk about Sadie being able to afford that transportation that she needs to come and see me and before she's labeled a non-compliant patient, or being able to afford the pharmaceutical medication before she's labeled a non-compliant patient. So those are the things that I think about when we think about these patients, and this is something that needs to be incorporated into our EHR systems when we talk to these patients in the time we have with them.
Yeah, and I think you're already starting to cover some of those things that I was going to ask you about. How can we healthcare providers be addressing these issues during our clinic visits with the patients?
Sure. That's a great question. It's, can your patient adhere to the therapy that you prescribe? It's a health and economic priority. If you think about it, this is a $300 billion a year non-adherence cost. And if you look at, that's according to the CDC, I didn't make up that number. You can look it up. The CDC has those data. And, a lot of these people don't have a lot of resources. Only 10% of the dollars that I'm talking about in terms of the billions of dollars we spend on our healthcare system is spent on actually education. So a lot of patients, when they leave offices like mine, do not understand what the breakdown of what their medication list actually should look like. Like, well, majority of them don't. And so what I do is I intentionally have my nurses spend time with them or my medical assistants, and then we break it down by conditions. This is your high blood pressure, your sugar or your diabetes, your high cholesterol. These are the medications you should take. If you end up in the hospital, you give us a call immediately, because the day you're discharged, I bet you they're going to mess up that whole medication list. Not to mention, by the time they present to the pharmacist, that whole medication list is going to be scrubbed out, because the pharmacist is going to say, well, your insurance does not pay for this, which is something that we don't think about, right? And by the time they're trying to advocate for these patients, the patients are just confused. They're confused. They don't know what to take. And that too can lead to catastrophic outcomes. So we spend 90% of our resources in terms of dollars on management and documentation, and less resources on education. And that's something we need to do as a healthcare community. And then we need to make sure that our patients can afford this optimal medications. And this goes to also the folks that make the medications. Affordability. It's not only access to care, access to quality care, but affordability, tolerability. Can they tolerate it? Can they afford it? I always inquire every single visit. What are the side effects? And are there alternatives? If there are, how can we get them to, and what are the cost effectiveness of that? And then what resources are available? Most of my patients don't even know what copay cards are, right? I have to sit there and explain that to them. So those are kind of the things that we go through with them on a usual basis. And I have to invest resources to be able to explain that to each patient that comes in the constrained timeline that we're afforded as healthcare providers to see these patients. So we just have to do what we can do, and then, rely on our partners. And that's why I think pharmacists are so underutilized in our healthcare space, so underutilized, from training all the way through our community. I think they need to be involved in that continuum and that interaction and that dialogue, and the respect has to be there between providers and the pharmacists, whereby they can help us better take care of our patients.
Excellent. I couldn't have said it better. Again, I think you're just really enforcing that the work that we do, that we want to do, nurses and pharmacists and all of our physicians want to work together as a multidisciplinary team to really provide this care. And like, as you said, it takes a team to make this happen, and we all have to own our parts to it to help our patients. So I'd like to continue with the case. I have a few more things to talk about in here. Kevin suspects Sadie may have PAD and knows the importance of wound healing being treated. Sadie asked a family member to bring her to the PCP clinic visit who she had to pay to bring her. She had to pay a family member to bring her to the visit. With her diagnosis, the clinician recommends a vascular surgeon to discuss of infected tissue on her pinky toe. Kevin advises Sadie to see a specialist in PAD prior to going through with surgery. Sadie is fearing the risk of having an amputation, but knows the importance to see a specialist, so agrees to going to see a specialist. During this time, I think Kevin also spends a little bit of time of telling Sadie the importance of getting maybe an ultrasound of her legs, and also importance of having an ankle brachial index, that he might talk to the nurse practitioner or nurse and having this patient have that done as well. He also is going to help her apply for health insurance because he noticed she's 65 years of age and may qualify for Medicare and Medicaid. With that, I have a few more questions for you. How would Sadie's quality of life been impacted by amputation if she were to move forward with that and not see a specialist?
Yeah, her hourglass would have been turned. So when someone has peripheral arterial disease, we're taught in our classrooms that you always seek that patient who's a claudicant or who has claudication. The definition of that is I walk a couple of feet and I stop, I rest. And when I walk, I have pain. When I rest, the pain is gone. That's the definition of claudication, but that's only 15% of patients. That's actually the exceptions, not the rule. Majority of patients have either atypical symptoms or are just basically meaning that they feel fatigued or their leg gives out on them, right? Mm-hmm. Or they have no symptoms at all. So that's why it's important to do a physical exam, know their risk factors, and based on the ACCHA guidelines, if they're over the age of 50, if they've had diabetes, nicotine use, and one additional traditional risk factor like high blood pressure, high cholesterol, if they've ever had a stroke or heart attack, like Sadie, stroke, she needs to be screened. And once she's treated for this wound is important because this wound is not only restoring circulation is important, and that's why identifying with an ankle brachial index or ultrasound was key, but who is the specialist that's going to restore that blood flow to her wound? You cannot heal a wound without good oxygenated blood flow. Mm-hmm. Once that wound is healed, she's great. She preserves her legs. It takes about 40 days for that to happen. But what you see in practice is that people see wounds, and even in spite of restoring circulation, within a day or two, limbs can be taken off. I've had that happen to my patients frequently. And so the key is to work with a team that understands the impact of taking off that limb. A major amputation, meaning any limb that is cut above the ankle, leads to a 25% death rate within the first year, 80% die within 5 years. Cost, I've told you it takes about $150,000 a year. The lifespan of that patient, $800,000. Most people cannot afford that. Prostheses are not even covered by certain insurances. That is an expense. What about chronic depression? What about chronic pain? What about infection? What about having a heart attack, a stroke because of that amputation? Those are common things that happen. And so it's that hourglass that gets turned immediately after an amputation. So the quality of life will be horrible for not only Sadie, but her family and also her community. You've taken someone who might be younger but functional to your community and taken them out. So it saps the strength of that whole community.
So when should there should be a referral for social services that you would recommend?
Yeah, I think this is a good question because social services should be recommended for every single person, including people like myself. I just think, when I go to, for instance, if I go to a dentist's office or I go to see an ophthalmologist, I need to know what my insurance covers. Or I need to understand what insurance is, right? Like, we're all smart. We've gone through medical school training, yeah, all that, 20 years of training or whatever you call it. But if I were to ask anyone to break down insurance from Advantage plans to, Medicaid and all the different plans at different states, it is tasking to know what's covered, what's not covered, let alone someone who has a 5th grade education, who is coming in to visit, who doesn't know if she's in a donut hole or not, right? These are challenges. So I think if that could be part of the team every day, or where they can come back to my office for a social services visit, just to see what their needs are, or even on a quarterly basis, I think that would be great. I just think that we're underutilizing those services, but because we just don't have the resources to have those services around. And that's something that our healthcare system has to focus a lot more emphasis and efforts towards in addressing social determinants of health.
And I know
being big for her as well.
Yeah, and I know we're going to get into the recommendation for anticoagulation next, but in a couple of questions. But one of the things I see in clinic is knowing a patient could be on rivaroxaban or apixaban, one of the DOACs, and right. I have to tell them they can't be on it because their insurance doesn't cover it. I know it's better for their life and their daily living and how far they live from clinic for warfarin monitoring, and it would be great, but they signed up for a Medicare plan that doesn't cover those. So I think even at the time when patients are filling out Medicare, Medicaid forms, I wish we had more services and more assistance for these folks to be able to get them on the right plan such that they can afford the medications that they need. So one of the things I do in clinic is, when I know somebody's going to be on anticoagulation, and while we've missed the ball or time already to sign up for the correct insurance that they need, I still write down the names of the drugs that they could be on and remind them, hey, when it comes in October, make sure you sign up for a plan that allows you to be on these other medications that might be easier for you to take. And then we have pharmacy technicians in our clinic who will then call patients in September, reminding them, hey, October's coming, make sure you change your plan. So those are some little things that we do in our clinic, but I'm sure there's other examples of things we can do as well.
Yeah, so that's awesome, by the way, and congratulations, because that practical awareness of what community-based resources are available, but also clinical-based resources are available is key. So yeah, that's a fantastic recommendation.
Yeah. How equitable care have saved the possible limb or life of a patient?
Yeah, I mean, there's something called the amputation lottery in America. It has to do with what are your chances of getting an amputation, minor or major, meaning your toe amputated or below the knee amputation. And so some of those risks are regional, geographical variations. So where you're located, if you're looking at diabetes belt in America, as I mentioned earlier, like the state like Mississippi, Louisiana, Arkansas, Tennessee, Georgia, right, Carolinas, you're more likely to get an amputation than someone who is in the Upper East Side of New York, or who lives in the Valley, or someone who lives in Sedona. That's one. Two, what are the specialists that are there that can handle peripheral arterial disease and its end stage? So access to vascular and high intensity care. Three, what are the specialists and the resources available? Are you in a resource challenge or a specialist desert? Do they have enough pharmacists where you are? Podiatrists, endocrinologists. We only have 7 in this whole state, right? 7 endocrinologists in this whole state, the #1 state when it comes to diabetes for the last couple of decades, only 7. So equitable care is important. It's not just access to care, but access to quality care. Do you have access to someone who can screen you in a timely fashion, who can address your risk factors, who can start you on all the medications you need, who can get you the appropriate screening tools and treatment tools that are in the toolbox that we have? Do they do appropriate angiogram before an amputation? Do they do a quality wound care before an amputation? Do they start you on medications that have been proven to have major adverse cardiovascular, lower your major adverse cardiovascular events, and also lower your major adverse limb events, like the rivaroxaban 2.5 BID, the vascular dose. That's the only drug that's been shown right now to have a mortality benefit, morbidity benefit, and major adverse limb events benefit in reduction. So it reduces amputation, stroke, heart attack, and cardiovascular outcomes before an intervention, during an intervention, and after intervention. So when a patient comes in and they're just on maybe aspirin or Plavix, these are the conversations we have. Have they had a bleeding event? Can they afford it? I need to talk to my pharmacist and all the and also the companies that and see what can we do to afford these medications? What can we do to stash these medications here so we can give to these patients? We need to explain the reasons behind that. So it not only ends at just the provider, but when they go to the community, can these patients continue taking these medications? Are there assistance programs that are available for them or to them? And their follow-up needs to be monitored. Nurses have to follow up with them vigilantly. Pharmacists have to follow up with them vigilantly as well. And also, we have to have those community navigators. That's where they come in to help them. Yeah.
So I think you highlighted the importance of anticoagulation professionals to really help with access to medication and informing the physicians when rivaroxaban 2.5 milligrams BID is not available to our patient or is not covered by their insurance. What can we do next? And I know in our previous conversations, you've mentioned availability of samples in your clinic that you try to provide to patients, which is amazing. And I know not all pharmacists or nurses can have access to samples, and there's laws and rules against some of that sampling. But I think from a physician, that is a little bit different. So I think that's nice to have some advice as to what we can do in terms of medication barriers, access barriers, and working together as a team to inform the providers when there is difficulty in access to healthcare needs, such as medication access.
Absolutely.
With that, I think that concludes the discussion of our case, and I wanted to open up for questions from the audience. And I think since we have a group of pharmacists, there are going to be few medication-related questions. So I want to get one of them answered. And while this is not a clinical case present or a webinar, but I still think there's this question about rivaroxaban twice a day dosing. So can you speak to the dual pathway approach of rivaroxaban 2.5 twice a day with antiplatelet therapy, and when or if can it replace an off-label therapeutic anticoagulation in some of the patients?
Yeah,
this person is from Mississippi Delta who asked this question.
Really? Oh my gosh,
yeah.
That's awesome.
Was born there, I guess.
Was born there. Right,
yeah.
Right. Listen, it's one thing that we were taught antiplatelet therapy, but people forget thrombin. Antiplatelet thrombin inhibition, thrombin inhibition are very important. Why? Because those pathways are what there's crosstalk, right? So thrombin actually can go and cause antiplatelets to aggregate even more. So we need to make sure that dual pathway DPI, pathway inhibition is in play. So that's why the aspirin and that rivaroxaban 2.5 milligrams plays a huge role. But as I mentioned, if you look at COMPASS study that showed that someone like a Sadie who's had a stroke, so she's had a cardiovascular event, right? And now has peripheral arterial disease. This was what the drug was perfectly made for, right? Someone who's had, both conditions has shown to have decrease in her major adverse cardiovascular events, right? Stroke, heart attack, and death. And then if Sadie comes to see someone like myself and undergoes a procedure, Voyager showed that, hey, she will have better limb outcomes, decreased amputation rates, decreased need for revascularization. And so it's the only drug that's out there. I mean, aspirin didn't show that, and Plavix didn't show that, clopidogrel, right? So this is the only drug today, and that's why I think the guidelines are eventually gonna, adjust for that. But I think that it's important to note that, hey, there are contraindications if there are patients have risks involved. If patients have a high bleeding risk, something to think about. If they need triple therapy, those that have had atrial fibrillation that need a high dose of anticoagulation based on your CHA2DS2-VASc score, that's something you have to think about as to, making sure they're an appropriate, not just putting them on a vascular dose, but the appropriate dose, and speaking with that specialist that's involved in the care. Affordability is the number one challenge for vascular dose Xarelto here in the Delta.
Yeah.
I'm sorry, I got to talk to my Janssen buddies, but that's what it is.
So you do prescribe sometimes dual
Absolutely,
anticoagulation
absolutely. There are just folks who cannot. There's a patient I saw today who was in donut hole, $500, can't afford it. I said, yes, ma'am. We'll do what we can for now. So what we do is we'll put her on that dual antiplatelet. And then when I get the stash back in terms of my shelf of the vascular dose, she's on that list. We're calling her, hey, come on, come get it. So that's what we do. We have to work with our partners, but sometimes you just have to do what you have to do for these patients.
Yeah, one more question about what should patients ask their doctor about their risk of PAD, and what should the patient look for on a daily foot inspection to report to their doctor?
That's a great question. Number one, do you have any signs of discoloration in your foot? Take off your socks at every visit if you have the following. You're diabetic, you have high blood pressure, high cholesterol, you've either had a stroke, a coronary disease, or a heart attack. If you've had chronic kidney disease, which is number one causes diabetes, if you had a family history of peripheral arterial disease, if you have any of those, when you go see a primary care doctor, tell them to check your pulses, tell them to check, to see if there's any hair loss, if there's any coolness, if there's numbness and tingling down your feet, if you have any symptoms of pain or throbbing, if you have any discoloration, as I mentioned, if your leg gives out on you. And just remember that, there are things that are pseudo PAD. So if you've had lupus, for instance, if you've had radiculopathy, meaning a chronic back issue, sometimes it's a nerve issue or small vascular issue, not a macrovascular issue. So making sure that definitely your pulses are checked. And then if there's any suspicion of diminished pulse or you have those risk factors, an ankle brachial index should be next. And if that is abnormal, which is less than 0.9, then you should see a vascular specialist, and appropriate medical therapy and supervised exercise testing should be initiated. And so those are the things that I start with.
Yeah. Thank you very much for your time today. I really appreciate all of your expertise and everything you shared about Mississippi Delta and how you're encouraging all of us to get out there and meet our patients where they are at. Thank you again for your time. I'm going to pass it over to Liz.
Thank you. Thank you for the privilege of invitation. Thank you very much.
Thank you so much to both of our speakers, Dr. Foluso Fakorede and Dr. Surabhi Palkimas. Thank you so much for this critically important conversation. Dr. Fakorede, thank you for your incredible work, as you said, making the invisible visible, and for combining your great compassion with the highest quality of care. You're having a huge impact on reducing health inequities and preventing unnecessary amputations. So thank you. And thank you, Dr. Palkimas, for walking through this really informative case. Very helpful. So just as a reminder, this webinar is accredited for physician, pharmacist, nursing, and lab and pharmacist tech credits, including ethics CE. I wanted just to remind everyone that AC Forum does have a rapid resource on social determinants of health and patient care. It's again a short 1 to 2 page guidance, and it includes actions that you can take as healthcare providers to improve patient care. So please check that out at this link or through the Centers of Excellence Rapid Resources. I just wanted to remind everyone that boot camp is in about 2 weeks, so please register for that. There's still space, and you can view it live on those 2 dates, but it's also available for 30 days after. And also save the date for our national conference in April in San Francisco. I wanted to let everyone know about AC Forum's IDEA scholarship opportunities. We have scholarships for clinicians from underrepresented racial and ethnic groups that are working in the field of antithrombotic therapy. And the application is on our conference website. We also have abstract research awards for clinicians either from underrepresented populations or clinicians conducting research on racial health disparities. And lastly, I think I want to remind you to register for our next upcoming webinar, which is in 2 weeks, discussing our brand new publication done in partnership with National Quality Forum on advancing anticoagulation stewardship, a playbook. It's available for free download and will give you tools, resources, tips of how to create a stewardship program. So with that, I'd like to thank our speakers again. Thank you so much for this amazing conversation, and thank our sponsors that help support our webinar program. Thank you and have a nice day.
Thank you.